It's my pleasure to introduce for this session Dr. Richard Phelps. He summarizes CV in a few lines, and I hope he's satisfied with it. Professor Phelps is a senior lecturer in nephrology at the Royal Infirmary of Edinburgh, previously at the Aberdeen Royal Infirmary and the Royal Postgraduate Medical School in London. He is a fellow of the Royal College of Physicians, and he was awarded a PhD by the University of London. He will be talking to us about an approach to patients with proteinuria. Proteinuria, as you all know, is a clinical and laboratory findings in medicine. It's very disturbing for the practitioners, for the nephrologists, and for everybody as a sign and as a risk factor. Professor Phelps, please, the floor is yours.
Mr. Chairman, ladies and gentlemen, thank you very much, and I'd like to thank the organisers for the opportunity to come and talk on this topic of how to approach a patient with proteinuria. I think it's very topical because whilst probably all of us were brought up to recognise that proteinuria could be a sign of significant renal disease, indeed persistent proteinuria pretty much is indicative of significant renal disease. More recently, a number of very large trials have slightly changed the goalposts in that it's been shown that proteinuria is a risk factor for progression of chronic kidney disease, and really rather surprisingly, it is also a risk factor for death or morbidity as a result of cardiovascular disease, acting independently, as far as we can tell in multiple regression analyses, from all of the traditional factors. So this was quite an unexpected finding and makes proteinuria of even broader interest than perhaps it was before. So I'd like to tackle this issue of proteinuria by, first of all, going through how the kidney handles protein. What is the mechanism, if you like, of proteinuria? And then I'll rehearse the causes of proteinuria to kind of set a framework. And then we'll get on to talking about how, at least in Edinburgh, we would approach a patient with proteinuria. And I'll slightly take them aside to talk about the tests, because they really are, proper interpretation of the tests can be quite tricky, and it's really pivotal to correct interpretation of the guidelines that are out there. So here's a cartoon. It shows the kidney, and the point of it is to show how the urine is created as an ultrafiltrate of blood within the glomerulus, which passes through the succession of tubules, within which the composition of the urine is modified to a very large amount of tubular reabsorption and a degree of tubular secretion. And with respect to how protein is handled, the really striking feature of this system is just how efficient the glomerular filtration apparatus is, such that blood, which is a soup containing enormously high concentrations of protein, albumin of 40 grams per litre, is filtered to create a filtrate in which albumin is present at only 4 milligrams per litre. So a very, very efficient filter. The filtration works partly on the basis of size and partly on the basis of charge. And the consequence of that is that glomerular filtrate does actually contain a fair amount of protein, but it's almost all low molecular weight protein, which gets through the sieving filter of the glomerular apparatus with relatively ease. Proteins less than 15 kilodaltons are extensively filtered. Things like insulin just go straight through. And in contrast, proteins, much bigger proteins such as albumin, only appear in the filtrate to a smaller degree, and much larger proteins, again, really don't cross the glomerular filtration barrier at all. The vast majority of protein which enters the glomerular filtrate is reabsorbed by those active tubular reabsorption mechanisms. And they do add a small amount of protein, but the end result of this is that is that the normal protein, it does contain some, sort of normal urine, it does contain some protein. It's wrong to say that there's absolutely no protein in normal urine, but it contains such small amounts that it is not detectable using the conventional tests that we have accessible to us. So in health, the urine might contain a total of 40 or 80 milligrams per day of protein, and of that, only 4 or 7 milligrams might be albumin. The rest is made up of low molecular weight stuff that was filtered and not reabsorbed, and tubular proteins. Now, larger amounts of protein can occur in the urine in health, and what separates these people from those who've got serious types of proteinuria is that it's transient. So whenever a patient has proteinuria and then goes away completely, that's enormously reassuring as to the presence of significant renal disease. There's a number of things that are recognized to cause transient proteinuria. It certainly can be caused in febrile states. It certainly can be caused by exercise. Anyone who's run a significant distance will have proteinuria for some hours. But it also occurs in many more, it occurs quite frequently in young adults, and there doesn't seem to be a good reason for it, but it always goes away. It's transient proteinuria. The amount of normal proteinuria does increase slightly by age, but only about twofold. And the other situation in which large amounts of protein can appear in the urine in health is called orthostatic proteinuria. And one recognizes this because the proteinuria goes away if you measure it after an overnight rest. So the first sample passed in the morning would usually be free of protein, whereas during the day, quite large amounts of protein might be passed. And why this happens is not really understood, but it is known that these people, unless they have very, very heavy proteinuria, have a good outlook and can be strongly reassured. So that's normal proteinuria, and that kind of sets the scene for defining what we're going to call abnormal. There's a number of ways in which you can approach this, and by far away the most common is just to talk in terms of the absolute amount of protein that is measured in the urine, so by total amount. And bearing in mind that 40 or 80 might be found in normality, it's conventional to say that greater than 150 milligrams per day is the threshold for saying a patient's got proteinuria. Greater than 3.5 grams a day is very heavy proteinuria. That's what we call nephrotic range proteinuria, and that's pathognomonic of a glomerular leak. In some situations, it's better to define proteinuria in terms of albuminuria. The advantage of looking specifically for albumin is that albumin detected in urine has come exclusively from the glomerulus, so it's a much better way of detecting a glomerular problem. And remember, in normality, you only have 4 or 7 milligrams making its way into the urine. Small changes in that will be undetectable in a sea of tubular protein mush that's in the urine. So, if you want to have the most sensitive indicator of glomerular illness, it is to measure albumin levels, and that's why that is the test that's used to pick up early diabetic nephropathy. But it's important to bear in mind that proteinuria can be, or urines and proteinuria can be abnormal also, because of the presence of protein shouldn't be there. So myoglobin in the context of rhabdomyolysis, for example, or light chains in the context of paraproteinemia. So how might abnormal proteinuria come about? And I find it quite helpful to think in terms of those various bits of the nephron. So, to start off with, it could be that the glomerular filtration barrier is not working as it probably should, and there's been an increase in glomerular permeability. I'm not going to go through these in great detail because these would be things that a nephrologist would have to deal with, but there is a number of different types of lesion that we identify in the glomerulus which cause this increase in glomerular permeability. And because there's so much albumin in blood, as soon as that size selectivity goes, the urine is drenched with albumin, which appears in the urine in large quantities. It's also possible for proteinuria to occur in states of chronic hypertension. We think possibly because of a stretching of the filtration apparatus, if you like. There's probably more to it than that, but certainly it's true that patients who have hypertension or very profound obesity develop quite significant proteinuria, more than half a gram a day sometimes. Tubular proteinuria can arise in a whole host of conditions. I've listed some there. And overflow proteinuria, the term refers to the fact that the kidney seems to be working normally, but proteins that would normally be entirely reabsorbed by the tubules aren't being entirely reabsorbed by the tubules, either because the tubule can't, or more often because the tubule is poisoned, or the toxins which are, when they're reabsorbed, are deleterious for the proximal tubule cells. So that's overflow proteinuria. And one should always bear in mind that after it's left the kidney, the urine has got to negotiate with the ureter, the urinary tract, and in its passage to the outside world will very often be contaminated by a number of things, such as the ones I've listed there. Probably urinary tract infections is one of the commonest reasons for proteinuria. So what should be our approach to somebody who's been found to have proteinuria? Well, I want to get this out of the way first. You should consider the possibility that this patient should be urgently referred for renal advice. And really the criterion is that there is overwhelming likelihood that there's significant renal disease. So very heavy proteinuria, more than 4 pluses on a dipstick, more than 3.5 grams a day, or a PCR greater than 300. Certainly if there's edema as well, this patient's like to have nephrotic syndrome. They need a type of investigation and treatment which a nephrologist can provide. I would add to the list of things that would prompt an early referral would be if there was a history suggestive of a new systemic disorders with the sort of symptoms I've listed there. And I think patients who are pregnant who develop significant proteinuria need to be put into a completely different channel. I'm not going to talk about that more today. So I threw up some numbers there, and I now need to qualify what those numbers mean, because I think the tests that we use to detect proteinuria need to be quite clearly understood. The commonest way to screen for proteinuria is to use the dipsticks that I'm sure are in all our clinics. And there's a number of things to remember about these. The first is that they're not very sensitive to such that they won't detect normal level proteinuria unless the urine is incredibly concentrated. And they only really start to detect, to develop a discernible colour change around the point where we would define proteinuria as being present around 150 milligrams per litre. I just mentioned the sensitivity limits of the usual quantitative laboratory tests. But what I really want to get onto is the fact that all of these tests, including the really very sophisticated ones at the bottom, which are trying to analyse the composition of different types of protein that are present, they all suffer from the disadvantage that they are looking at the concentration of the urine that's made available, whereas all of the guidelines and definitions that you'll see are generally in terms of the amount of protein that's passing per day. And clearly the volume of the urine is not a constant. It can vary really quite substantially, enough to move the concentration of protein in the urine around quite a lot. And the conventional way of getting around this is to ask patients to do a 24-hour urine collection. We're moving away from that because it's been well known for ages that patients find it very difficult, it's inconvenient, and they don't do it very well. And increasingly, we're turning to these ratios. The PCR, that's the protein creatinine ratio, and the ACR, that's the albumin creatinine ratio. And what these do is they form a ratio of the protein concentration in urine to the creatinine concentration in urine. And the underlying presupposition is that the amount of creatinine that's excreted is constant. So by looking at that ratio, you overcome the fact that the urine might be very concentrated or very dilute. So these are increasingly being used because of this ability to compensate for urine concentration. They are certainly very, very useful for monitoring. The criticism of these tests is that they do rely on the creatinine secretion of the individual being predictable. And as we know from attempts to predict what someone's GFR is from their creatinine, it's actually quite a lot of variation. But once you know what it is for an individual, for serial monitoring, they're very useful. So this is the sort of rule of thumb guide that we use. I noticed from the previous talk that you're measuring creatinine in milligrams per litre rather than millimoles, so I'm afraid these numbers will be a bit out for you, but we get the PCR reported in milligrams per millimole, and there's a rough 10-fold relationship between PCR expressed like that and 24-hour creatinine clearance. That's a really easy way of translating back and forth between the two. And the caveat is that it will underestimate protein excretion in patients whose creatinine excretion is higher than 10, so most men, for example. So now we know how the tests are working, how are we going to approach the patient with proteinuria? Well, it's important to start from the standpoint that persistent proteinuria is abnormal and implies intrinsic renal disease. So this is not something which can be, in any sense, dismissed. But before getting into the sort of flowchart, it's very important to be clear that the proteinuria is consistent. So the first step would be to repeat the estimation on a separate sample on a separate occasion to make sure that it is consistent. And it would be sensible for that repeat test to be an ACR or PCR, so as to make it less sensitive to concentration, and to make sure the urine was collected out with fever or exercise, or other things that might obviously cause a false positive, so as to have a sample which you can hang your hat on as evidence that the patient's got proteinuria. I'd advocate, if you haven't done it already, doing a PCR in order to quantify the amount of protein, because most of the guidelines that are out there relate to quantity in terms of defining what would be an appropriate path, and certainly the amount of proteinuria is an indicator of how severe the problem is. And if you make your PCR test an early warning sample, that affords an opportunity to exclude orthostatic proteinuria. So having become clear that a patient's got persistent proteinuria, I think that this sort of assessment would be reasonable for a general physician or a primary care to undertake. Certainly we ask general practitioners to do this. Take a history, blood pressure, assess what renal function is, seek evidence of diabetes mellitus, because that's going to change a lot when you do a quantification as we've discussed. And then we provide these referral guidelines. These aren't written in stone. We suggest that anyone with a PCR more than 100 should be seen by a nephrologist. We ask if someone's between 50 and 100, we suggest they give us a call and we discuss it. So they're not written in stone at all. A lot of things would tip us towards seeing a patient in the renal service. Younger patients, because they're at greater risk of progressive renal disease. If there was presence of hematuria as well, that would suggest possibly a glomerulonephritic process. The presence of hypertension, any history to suggest there might be a systemic illness, and if there's a family history of renal disease. So that would tip us towards seeing the patient. And I think the purpose of this talk, once the nephrologist has taken over the patient, it becomes their problem. And the problem really is what to do with the other patients, the ones that fall between. You've got proteinuria, they don't really warrant a referral to a nephrologist, but they certainly need managing for the reasons I outlined on my very first slide. They need managing to reduce their risk of progressive kidney disease. In many cases, that's going to amount to starting an angiotensin converting enzyme inhibitor or an angiotensin receptor blocker. And to control blood pressure to a low target, we are strong advocates that in the presence of proteinuria, in fact, of chronic kidney disease in general, but proteinuria in particular, that the target to which blood pressure should be treated is lower than would be the case for the general population. I'll come back to blood pressure targets in a minute. But also these patients need to be managed because they've identified themselves, if they weren't already known, to be at high risk of cardiovascular morbidity and mortality into the future. So I think that should act as a prompt to do all the things you can already do in terms of assessing cardiovascular risk. It's not clear yet that treating the proteinuria is actually going to affect the outcome. At the moment, proteinuria is just known to be a flag, although there is the PREVENT study, which is just hinting that there might be a benefit from treating the proteinuria per se. But at the moment, we don't advocate that. And the third reason why these patients need to be monitored is that it could be just pick them up at an early stage in the evolution of very significant renal disease. They need to be monitored. Initially, we'd suggest 6 monthly, but then that could be spaced out a bit. The point of which is to pick up if they're going to develop progressive renal disease and require assessment. This is a shocking slide because it shows how renal survival is profoundly influenced by the level of proteinuria. So the patients being examined here had varying degrees of proteinuria between less than 1, 1 to 3, or greater than 3 grams in 24 hours. We're looking at renal survival at intervals. And it's very clear that heavy proteinuria is associated with very much less good renal survival. And in contrast with the influence of proteinuria on cardiovascular risk, we do know from good studies that treating patients with proteinuria with angiotensin-converting enzyme inhibitors to reduce their proteinuria does reduce their rate of progression to chronic disease. So I said I'd come back to blood pressure targets. So at the start point, it's absolutely clear that lower blood pressure targets are beneficial in patients with proteinuria and chronic kidney disease. It's not clear what the lower limit should be, whether you carry on getting benefit however low you drive the blood pressure, although clearly lots of patients don't tolerate it being driven that low. Those are the current UK guidelines, signed by NICE organisations that produce guidelines. And they're suggesting a target blood pressure of 140 over 90 for patients with a PCR of less than 100, and a lower target of 130 over 80 for a PCR greater than 100. That is our national guideline. I have to say we ignore it. We would treat people to a lower blood pressure target if their PCR was even as low as 50. Having said that, I think when looking at these guidelines, it's very important to remember that blood pressure treatment for these indications has to be individualised. And in fact, I haven't reproduced it here, but what we have in our clinics is a list of what the normal blood pressure is by age and sex. Because I think the objective of blood pressure treatment in these patients should be to lower blood pressure below what would be normal for their age and sex. So that's what we mean by individualising the treatment. I should mention diabetes. Most of this is managed by diabetologists, but it's very, very clear that diabetics who developed even very low levels of proteinuria should be on an ACE inhibitor or an ARB. And many people looking after diabetologists with proteinuria would recommend the lower target of blood pressure, even than the one that our NICE organisation is recommending. In terms of choice of hypertensive drug, I think it's very clear that ACE inhibitors and ARB blockers, it's very clear that ACE inhibitors are effective. Probably the case that ARB blockers are as good. In the situations where you can't use either, there are some reasons to think that the non-dihydropyridone calcium antagonists would be better than nifedipine and the like. So we're in that situation with use of retinol or diltiazem. So I think the key points, last slide, are these: that any abnormal proteinuria is a significant risk factor for progressive renal disease and for cardiovascular morbidity and mortality. So it has to be taken much more seriously, perhaps, than we might have done in the past. And unlike hematuria, which has a whole bunch of causes, proteinuria is almost always of renal origin, and persistent proteinuria really implies intrinsic renal disease. Slightly surprisingly, perhaps, the risk of renal failure is greater in younger patients, whereas the risk of dying from heart disease is, not surprisingly, greater in older patients. And it's really important to bear in mind that the risk can be altered by therapy. This is some of the situations that we've talked about. And the most important intervention that can be made is to control the blood pressure to low age targets, preferably with an ACE inhibitor or ARB. I just finished with the URL of the website that we maintain, which has the Edinburgh guidelines and a whole lot of other information for patients that you can use as well. That's been done. Thank you very much.
Thank you. Dr. Phelps, thank you very much for your nice lecture.
Thank you very much. I think this title would have seemed bizarre only a few years ago, because dialysis was very much a rare procedure, very much under the supervision of nephrologists. So what was dialysis for general physicians all about? But I think that, in fact, the title is very relevant today, because dialysis is now a much more widely undertaken procedure. And it's increasingly likely that all medical disciplines are going to be confronted by dialysis patients. And I'm hoping, in the points I'm going to make over the next few minutes, to give you some pointers to some of the pitfalls that lie there and how they might be avoided. And the approach I'm going to take is to, first of all, just run through how we provide renal replacement services. I'm going to focus very much on hemodialysis, because that is the most invasive modality. And then I'll go through some of these particular problems of dialysis patients and how the management issues that present to non-nephrologists might be managed. So, treatment of end-stage renal failure, unlike most other organs when they fail, we are able to replace the function of the kidneys with dialysis treatments or vitamin transplantation. And hemodialysis, represented in this cartoon here, is a very effective procedure in which blood from a patient is pumped through a artificial kidney, in which the blood is in close proximity, separated just by a semi-permeable dialysis membrane from a filtrate of cunningly constituted electrolytes, such that the returning blood has the desired composition to correct the imbalances that have arisen in the patient as a result of their own kidneys failing. And this procedure needs to be repeated 3 times a week for 3 to 5 or even 6 hours per patient. And because of the need to maintain a circuit for that duration of time, it's necessary to anticoagulate the patient for the duration of the treatment. Peritoneal dialysis has the advantage over hemodialysis that it's not necessary to remove the patient's entire weekly fluid intake in just 3 sessions, which results in quite extreme fluid shifts for more profligate drinkers. Peritoneal dialysis, in contrast, is a continuous process in which we dialysate fluid into the peritoneal cavity, this sort of virtual space between the visceral and parietal peritoneum. You can put a plastic tube into that, a tension-off catheter, and instill fluid, and dialysis occurs across the membranes between the peritoneal cavity and the capillaries which are lining the peritoneal membranes. And this enables dialysis to occur. It needs to be undertaken continuously to be as effective as hemodialysis, and the usual procedure is either to instill 1 to 2.5 litres 4 times a day, which is continuous ambulatory peritoneal dialysis, or increasingly now one can get machines that will do this cycling overnight for the patient. It does result in much smaller fluid shifts, and we like to use it for people who are very poorly tolerant of those fluid shifts, for example, people whose cardiac status is dodgy. But it is of limited effective duration. In practice, one is unlikely to be able to continue this for more than 5 or 8 years because the peritoneal membrane becomes abnormal. And lastly, just to mention, passing transplantation, because transplantation is by far and away the preferred modality. If any of us develop chronic kidney disease, we want to have a transplant because we'll feel better and we'll live longer. It's very hard to argue against it, apart from the fact that we need to find kidneys. Now, dialysis is just the mechanical part. In order to sustain sustain health. Patients have to buy into really quite a complex packet of additional measures. They're essential additional measures. They need to get an access form so that it's possible to get blood in and out, or peritoneal dialysate, fluid in and out, at the sort of rates that are required. They need to comply with the dialysis regimen, which is onerous. 3 times a week in a particular space for 5 hours. A lot of people find that very challenging. They have to have a strict diet in which they limit their potassium and phosphate intake, whilst taking enough calories and protein so as not to lose weight. They will always have to restrict their fluid intake, typically to about 800 mils a day, and take a number of medications that I've listed there. But this regimen is sufficient to sustain long-term life. There are many people who've been on dialysis in moderate health for 20 plus years, even in full-time employment. However, it doesn't restore normal renal function. It at best gets close to around 8 to 15 mils per minute of effective GFR. So they're in a state of chronic renal insufficiency. And many describe continuing marginal well-being. It's common for, in fact normal for ladies to be anuric. If it's a child, growth is likely to be impaired. And now we also know that having renal failure is in itself a very strong and independent risk factor for developing cardiovascular disease in the future. This slide emphasises that last point because it shows quite alarmingly the annualised mortality for patients on renal replacement therapy versus the normal population. And this is a log scale. So we're talking about a 1, 2, almost 3 log increase in risk of death on an annualised basis for young people on dialysis. Interestingly, possibly because these are self-selected survivors, the curves become much closer for older patients. I thought I'd show you the outcome data from Scotland. All patients on renal replacement therapy in the United Kingdom are entered into a registry, and we can report our figures periodically. These are the figures from 2010. And these are an important way of gauging how we're doing in terms of keeping our dialysis patients alive. And you can see that, as I said, if you're young, so what I'm showing here is median survival in years by diagnostic group and age. And if you're young and you've got a type of disease which just affects the kidney, so you haven't got some sort of systemic illness as well, then your outlook's pretty good. Whereas if you're older, and particularly if you've got diabetes, your median survival on dialysis is pretty grim. And even when we're patting ourselves on our back for keeping these people alive, if you compare their survival with the life expectancy of people without kidney injury, kidney failure, these patients have a relatively poor outlook. So how does all of this impact general physicians? Well, I think the impact is going to be substantial, even if it's not already. The prevalence of providing dialysis is increasing. Certainly the demand for it is increasing as our populations age and diabetes and hypertension become more prevalent. And not only are there more patients around, these patients have a very high morbidity, so they're very likely to develop problems that take them into acute receiving or almost any part of the health service. And probably in most setups, nephrologists aren't going to be available in sufficient numbers to manage these patients in all of these different settings. Probably nephrologists are going to manage the dialysis, and others will be confronted with the dialysis patients in all sorts of complicated settings. So what are the problems that they're going to face? I'm going to say just a little bit about the problems that occur actually on dialysis. And the reason I think I should mention this at all is that an awful lot of dialysis happens in satellite units, which might be really quite remote from a nephrologist, and it may well be that a general physician will be the first person on the scene. But then I'm going to focus mainly on the sorts of problems which these patients present whenever they turn up. So on dialysis, there's a distressingly long list of things that can go wrong. Hypertension is very common, muscle cramps are much less important, but unpleasant for the patient. I think for the general physician, the point to be aware of is that hypertension is common. It's always to do with the fact that once removed fluid on dialysis more quickly than the patient can adapt to it. There are a number of very serious things that can happen, and these tend to be medical emergencies, cardiac arrests, sometimes as a result of bleeding into the pericardium. Intracranial bleeding is a result of having to anticoagulate patients who want to do dialysis. If they've got a leaky capillary, they might well develop intracranial bleed. Acute hemolysis can happen on dialysis if someone's dialed up the dialysate concentration completely wrong. And if the circuit has become disconnected in some way, such that the air is being pumped back into the patient, it shouldn't happen, the machine shouldn't allow it. But air evidence is something to be aware of if you see someone in arrest with a pulseless state. So back now to the things that everyone's going to have to face. And one has to start with fluid electrolyte problems, because these are the most obvious issues. And the first point, perhaps unexpected, which I'd like to make, is that a lot of patients on dialysis, especially in the early years on dialysis, they do retain some urine output. And that is very important for them, because it means they don't have to cut down their drinking so much, and it probably does mean they have slightly better overall renal function. And it's important for us to realise, because it means that it's still important to try and preserve their renal function. So we shouldn't be giving them nephrotoxins or allowing them to get dry, because if they lose that residual urine output in the context of whatever's brought them into hospital, it will be doing them harm in the future. The usual story is that somebody comes into casualty fluid overloaded, and they're a dialysis patient and they've drunk too much. This is always related to fluid consumption between dialyses. Sometimes it's not the patient's fault, sometimes they've got some other problem which is causing them to lose weight. And the way dialysis happens when it's on a remote pilot is that people are dialysed to some weight that we specify. So if they've lost flesh weight, they'll actually have fluid pumped into them on dialysis, and that could be how they've ended up being in a state of pulmonary edema. But most of the time it's because they've drunk too much. People present with pulmonary edema, and it usually requires urgent dialysis to remove the excess fluid, because they're not going to respond to diuretics, or if they do, they'll respond extremely poorly. It's useful to know the holding measures that dialysis may not be available straight away, but you do have the option of obviously supplemental oxygen, but also CPAP is very effective at putting fluid, interstitial fluid out of the lungs back into circulation, and nitrates, intervenous nitrates, are very effective at buying some time until dialysis can be set up to remove the excess fluid. And it's always worth bearing in mind, whilst we're assuming someone's drunk too much, that it may be they've had a silent myocardial infarct, and the problem's not that they've got fluid overload, it's that their heart's not working so well. And the other common scenario is that patients turn up with hypokalemia. And I think here it's important to bear in mind that a lot of dialysis patients are used to being hypokalemic, and that when they come in to have their dialysis, they quite often will come in with a potassium of 5.5 or even 6.5, and then they'll be dialysed down to 1.5, 2.5. So it's not necessarily the emergency it might be in someone who's not a dialysis patient to treat a potassium of, say, 5.5 or 6.5 millimoles per litre. But a potassium greater than 7, and obviously if there's ECG changes, does require arrangements to be put in place to remove dialysis. The usual holding measures that drive potassium into cells are available. You could give salbutamol or dextrose and insulin, but it's only buying you an hour or so. You need to arrange for dialysis. Infections are a big issue. It's the second commonest cause of death in dialysis patients, and it must be one of the commonest reasons for them coming into hospital. It's important to bear in mind that being in end-stage renal failure or some form of renal replacement is an immunodeficient state, and a lot of these patients would have had a transplant or two, so have had periods of time on immunosuppression. So they are immunosuppressed patients. One of the commonest sources of infection is iatrogenic. It's because we have to use lines in order to provide dialysis. So we have indwelling lines, even tunneled lines, are very common sources of infection, and probably line infection is the commonest reason for dialysis patients to get admitted. This can be a huge problem, and the prevalence of the problem depends very much on how good your vascular access surgery services are. Where vascular access is good, or where it can be made good, this problem can be reduced enormously. It can be associated with very serious complications, and in fact, in my own unit, before we got our vascular access services better sorted, we had a whole succession of patients with problems like this. Recurrent episodes of bacteremia associated with lines, complicated then by endocarditis, or this unfortunate person got a discitis, which then burst to make a paravertebral abscess. So these are very serious complications of less than perfect provision of access, and Staph aureus sepsis should always be suspected in a septic dialysis patient. But I also want to mention some other things. Dialysis patients tend to get some slightly unusual presentations. So pyocystis is not something you see in contexts where people pass urine. But if you don't pass very much urine at all, and infection gets into the bladder, you can get pus in the bladder, which can make people unwell with really quite odd symptoms, maybe a bit of abdominal pain, maybe just a gram-negative septicemia. And cholecystitis often also presents in a non-typical way, and it may be that gram-negative bacteremia is the only indicator, and they've actually got cholecystitis. Another thing about dialysis patients is they tend to get organisms that we usually associate with debilitation. So we see fair amounts of TB, unfortunately some pneumocystis, and also deep-seated fungal infections, which can be very difficult. And lastly, I should mention blood transmission. This is obviously something which we are, I hope, in all dialysis units extremely aware of now. We're critically aware of it in Scotland, because we actually had an outbreak of hepatitis with transmission between patients and to staff, admittedly back in the 70s, but we still bear the scars. And throughout the world, this is a problem. Hepatitis C, I understand, is really quite prevalent in some parts of Jordan, for example. So with that sort of preamble, the management of infection in a dialysis patient, it needs to be very prompt, but I think it also needs to be very wary, because it might not just be a normal infection, it might well be one of these odd infections that I've talked about. So it's even more critical than usual to collect good data, to collect several cultures from different sites, for example, including from a line, if there's a line there, to collect sputum. If the patient doesn't pass urine, consider doing a bladder scan to see if there's something in the bladder which might be aspirated, which might be a sort of infection. So we're very keen and strongly recommend that more than usual effort is made to get samples before antibiotics are started. And I slightly hesitate with an ID professional in the room, but we would normally go in with quite broad spectrum antibiotics quite early because of the speed with which these patients become very ill. And the last point is, I think, very important, and it will depend on your local circumstances, but we've benefited enormously by building strong links with the local ID professionals or microbiologists so that they review our samples on a daily basis, and we have a constant conversation with them about the best way to manage these patients, because they're not straightforward. So I must mention cardiovascular problems. This is the commonest cause of death in dialysis patients regrettably, and the etiology is not quite the same as the general population. It's not so much that there's thrombi forming on atherosclerotic plaques and causing acute myocardial infarctions, and more that there's calcification within the media of very stiff vessels, and both patients still do quite clearly get myocardial infarcts, but they're not quite the same. They're quite often silent. They quite often present with just a troponin rise and maybe some breathlessness, or maybe some blood pressure instability. So something which we train our juniors to be constantly aware that there may be some silent myocardial problem going on to explain any presentation, really. It's not just ischemia. Left ventricular hypertrophy is almost a norm in patients who've got end-stage renal failure, because of a long time they'll have probably had borderline hypertension. And aortic stenosis is a particular problem. Calcific aortic stenosis is common in the elderly, and calcium disturbances are common in dialysis patients. The two seem to collide such that it's possible for calcific aortic stenosis to progress incredibly rapidly. I've seen people go from 30% on an echo to near 90%, very over less than a year. It can progress extremely rapidly. In terms of how we manage these cardiovascular problems, we're in a bit of a bind. We do all the obvious things in terms of minimizing risk factors, but in contrast with the general population, I think we've got much less strong evidence that we're going to do good to the patients by doing things like putting them on statins. I must say we still do that, but it's less clear that we're doing good benefit. We certainly try and manage calcium. I think the most important thing is to have a heightened awareness that cardiovascular problems are so common. So bleeding, patients in end-stage renal failure do have a bleeding tendency, and it's due to platelet dysfunction. And I think, and obviously compounded by thrice-weekly anticoagulation, but this is something which I think should be very much in your mind if you're planning an operation, particularly something like hip replacement, in which blood loss can be quite substantial. It's quite likely that there'll be more blood loss and greater need for transfusion. And if you do find yourself having to transfuse a dialysis patient, this is actually quite tricky because you can't give them some frusemide except to pee out the fluid that goes with the red blood cells. It has to be done with very, very close attention to their blood volume. In fact, we would normally give blood on dialysis if that was an option. And if there's any possibility the patient's going to be transplanted in the future, it would be better to make sure the blood was red white blood cell was depleted. There are a couple of unusual things that you can do if you've got a dialysis patient who's bleeding for whatever reason. DDAP has the temporary effect of releasing factor VIII from endothelium, and that can help arrest bleeding. And on occasions we have resorted to conjugated estrogens, which just make the blood more sticky, I think, in patients who may not be able to pin down the source of bleeding. But prevention, I think, is very important, and it's important for everyone to be aware that a patient on dialysis or indeed with advanced renal impairment, they're not going to handle low molecular weight heparins in the normal way. And in fact, they are very easily over-treated with what is becoming the standard prophylaxis with DVTs. So we don't recommend low molecular weight heparins. We use standard unfractionated heparin as prophylaxis for DVTs because of this problem. And the other thing is that patients, these patients are much more at risk from bleeding if they're treated with warfarin. And all of the evidence for the benefits of warfarin in settings such as atrial fibrillation have usually excluded patients with this particular problem. So we don't really know that you're better off on warfarin if you're on dialysis and have atrial fibrillation. And that I think creates problems when you've got burns in the past and extrapolating from what works for the general population to what works for dialysis patients. I think this is probably obvious, but I have to mention that whenever one is prescribing a new drug for a patient on dialysis, one has to look up the appropriate literature because there are dose adjustments required really very frequently. And there are drugs that we would recommend avoiding, such as non-steroidals, and for the reasons listed there. A lot of people don't realise that penicillin is excreted renally, and if you're using a high dose of penicillin, as you might be for a serious infection, then in a patient on dialysis you can precipitate convulsions. And whatever the maximal dose of the penicillin you're using is, you probably ought to halve it if somebody's got advanced renal impairment. And if you're using aminoglycosides, which are antibiotics, which are enormously effective, the usual way we would give them is to give a single dose and then wait for the levels to drop to a safe threshold before we dose again. So, something else I want to mention, which is really the problems of nephrologists, but quite often this problem presents first to general physicians, and the thing is to be aware that it's an emergency. If someone's access, their fistula, clots off, then from the point of view of the patient, that is one of relatively few places where you could form a fistula gone forever unless it can be rescued. So depending on what your local services are, it may be that there's a vascular surgeon or an interventional radiologist who might attempt to rescue that fistula, or it might be that you just have to resort to trying to infuse heparin in or something, but it is an emergency because loss of that access is so critical, and we would always try to do our best to rescue it if possible. So I just want to finish with this slide, which lists some of the sort of pitfalls that I think you might come across if you had a dialysis patient maybe coming for a minor procedure or something. And these are some recommendations. First of all, I think that in respect of fluids, if at all possible, the patient should be allowed to consume their normal oral fluid allowance and diet. If you are going to take over their fluid management for them, then you're going to have to think a bit differently to perhaps you might normally think. And very often all that's needed is to replace their insensible losses, plus any residual urine output if they happen to have any. And certainly if it's a more complicated situation, it's the sort of scenario which nephrologists would very much like to be asked to be involved. If there's going to be any skin cutting involved, we'd recommend that the procedure be scheduled for the day after dialysis. The patient's biochemistries should be good at that point, and the anticoagulant will have got out of their system. If the procedure is going to, I've already mentioned having a lower threshold for cross-matching blood. If the procedure is going to involve any muscle cutting, then we recommend that a serum potassium be checked maybe a couple of hours after the operation has been completed, because sometimes very large amounts of potassium are released by this, and if the patient's unable to clear it, they may need an extra dialysis that night, and that's something we've had to do on many occasions. It would be very kind if people could bear in mind the importance of vascular access and maybe inform the staff that they shouldn't be taking blood from a fistula. They should indeed, we would prefer that blood wasn't taken from the same arm as a fistula, or any veins that might one day be used for a fistula. So that's anything between the wrist and the elbow. Access for many patients is life or death. So, and if any temporary access is going to be implemented, then be more than usually vigilant to try and prevent those accesses becoming infected. Maybe institute some sort of Venflon dating. We put a tag on all the Venflons for the date they're put in, so that we can watch to remove them before they become infected. We'd recommend having a lower than usual threshold for using prophylactic antibiotics if any skin cutting is involved, especially if there's some plastic access sitting in which could become seeded by Staph aureus introduced through the skin. So we'd routinely cover those sorts of procedures with an anti-staph antibiotic and anti-mouth organism antibiotic if there's going to be oral surgery. We would have a very low threshold for adding in a PPI if there's not one there already, because patients on dialysis are at increased risk of stress ulceration. Whatever they're in hospital is going to probably add to that stress, then we'd consider a PPI. We'd avoid low molecular weight heparins. We'd avoid gadolinium because, unfortunately, there's been a number of cases now of patients with advanced renal impairment with gadolinium with MRI developing a very horrible fibrotic process which has proven lethal in a number of patients. And we don't fully understand why or who's going to get that yet. For the moment, we just avoid gadolinium. Be very careful about the dose and dosing interval of any new medications. To highlight opiates, a number of times we get asked to see people who've been over-opiated and rendered seriously ill purely because of the opiates. If you have to use a strong analgesic, fentanyl is the one that's best cleared. So I think the key points really in dealing with a dialysis patient, a non-nephrologist, is to have a sort of informed wariness in how you approach them. Be very suspect of any drugs you're going to prescribe, or of any of the possibility they might have infection, or the possibility they might have an implant that's not declaring itself in the usual way. To anticipate the fact they're going to bleed more than the next patient and do whatever you normally do, but more so. And to recognise that they develop problems like fluid overload or hyperkalemia, they may well need an acute dialysis, and perhaps they should be having this procedure where acute dialysis is more readily available. Try and preserve the native veins, and most of the nephrologists know their dialysis patients very well and would be delighted. The patients are complex, so give us a ring. We'd be delighted to give any advice.
Well, thank you very much for your kind lecture. We are already behind our scheduled time. We are 5 minutes. We are allowed one question, please. Yes, sir.
Dr. Richard, thank you for lecturing on this important topic, proteinuria. Now, if in Sweden, Britain, US, all developed countries, only around 30% of treated hypertensive patients are controlled. Now, the constantly variable guidelines, I think it creates some sort of misleading situation. And now we have GMC 8 after GMC 7, and I ask myself, if they told me no more important to keep diabetic patient hypertensive on 120/80, I ask myself, what is the harm to keep him on 120/80? And these variable, constantly variable guidelines, again, in hypertensive treatment, in LDL target, and now before a couple of months, HbA1c. Do you think that in addition of individualized treatment, that everybody agree, that another factors, socio-economic, cultural factors, play a role?
So you slightly answered that. But what I say about guidelines is that they should be applied individually. And when I talk about individualization, the example I gave was blood pressure. But there'll be other circumstances that make it appropriate to modify what guidelines are recommending to that patient's individual circumstances. I don't see any problem with invoking any of the factors that you mentioned, if that's a judgment that you think is right for that particular patient.
Thank you, Professor Phelps. Thank you, colleagues. For the time, we have 5 minutes coffee break before we come back for the second session, please.
دكتور لو سمحت انت وياه وين رياض؟ حاجه معك طويل يا زلمه يلا صورني مع الطويل رياض حبيبي رياض نبيل تعال نبيل تعال يا نبيل ابو محمد مبروك يلا وين راح علينا